Hello, and thank you for joining our podcast, Non-Small Cell Lung Cancer Morning Commute, What's on the Horizon? Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals and Sanofi Genzyme. Information about the faculty and disclosures can be found at morningcommutepodcast.com/NSCLC3. You can use this link to receive your credit and evaluate this program. This URL can be accessed in the episode notes. You can also find the complete three-part series by visiting morningcommutepodcast.com/NSCLC. Joining us today is Dr. Naya Rizvi, who is the Price Family Professor of Medicine in the Division of Hematology Oncology at Columbia University Irving Medical Center in New York City, and Dr. Sarah Goldberg, who is an Associate Professor of Medical Oncology at the Yale Cancer Center, Yale School of Medicine in New Haven. In this episode, Drs. Rizvi and Goldberg discuss new therapies in the pipeline as well as immunotherapy combinations. At the time this podcast was recorded, cemiplimab was pending approval. I am your host, Candace Hoffman, Managing Editor of Morning Commute. Dr. Rizvi will begin our discussion.
Welcome to Podcast 3, What's on the Horizon for Lung Cancer. My name is Naya Rizvi from Columbia University. I'm joined by Sarah Goldberg from Yale. And we first started using immune checkpoint blockade for lung cancer. It's been, I think, around 12 years ago now, which is pretty remarkable that when we think back to the first days when we had our first patient that got nivolumab and how excited we were by their responses. I remember one of my first patients, this is over 10 years ago. He had a big adrenal metastasis and he was in clinic and, he was having a lot of pain and from the adrenal mass, and he got his dose of nivolumab and he actually had to go to the urgent care for some IV pain medications. And then he went home and then he woke up the next day and he had absolutely no pain. And, this is one of your first patients, you drink the Kool-Aid that this is really the future of lung cancer. So currently we have pembrolizumab approved in the PD-L1 more than 50% population, as well as atezolizumab approved in PD-L1 high patients. This was actually a trial with cemiplimab was actually an interesting trial because they used the same PD-L1 assay, the 22C3 assay as Keynote 024. And so it's a very similar study design, randomizing patients to randomizing patients to cemiplimab or chemotherapy with the primary endpoint of overall survival. It was also an interesting trial because it was really kind of a real world population where patients did not require to have stable brain metastases. They could have had, as long as their brain mets were treated, they were enrolled on. Patients with a history of hepatitis or HIV were allowed on. And there was a significant proportion of squamous patients that tend to do worse. So it is kind of a very clear registration trial, but more real world in terms of patient eligibility. And it very clearly met its primary endpoint of overall survival. It will be reviewed by the FDA for approval in February of 2021. And I think it's great that we have other immune checkpoint inhibitor trials as treatment options in the first line setting. Also in this trial, they were able to study the magnitude of benefit by the actual threshold of PD-L1 score, and the patients who had the more than 90% actually did exceedingly well, suggesting that not just more than 50% threshold, but by increments we can see a correlation with benefit. So more data in terms of likelihood of response based on PD-L1 testing, real world evidence data showing that PD-1 therapy in the first line setting is sort of here to stay as a first-line treatment option for the more than 50% group, and we have now more than one treatment option.
Yeah, I agree. I think this trial is really exciting. It shows, just as several other trials have shown now, that PD-1 inhibitor alone can be or is more effective than chemotherapy. Clearly, overall survival is better in these patients with PD-L1 greater than or equal to 50%. So I expect that it will be approved. based on this positive outcome of overall survival. And I agree, it's nice to have another treatment option for patients in the first-line setting.
But I think, I think we had a lot of excitement around some of their new immunotherapy targets, such as other immune checkpoints, such as LAG3 and OX40 and others. And, it's been harder to crack that nut in terms of moving us to the next level. We definitely have options now in the first line setting for lung cancer. We talked in podcasts 1 and 2 about first line pembrolizumab, ipilimumab and nivolumab in combination, and the different chemotherapy combinations with pembro and chemotherapy or atezolizumab and chemotherapy. And, one of the more newer combinations that was approved is what was called the 9LA regimen, which is a combination of abbreviated chemotherapy with 2 cycles of chemotherapy in combination with ipilimumab and nivolumab, the concept being that the immunotherapy drugs can take a little bit of time to work. So if you're able to give some initial chemotherapy to and do some synergy with the immunotherapy, get some cytoreduction, and then give the immunotherapy time to work. And that also was a regimen that was recently approved. Sarah, have you used 9LA yet?
I have not. I haven't had the opportunity. I haven't thought that it was appropriate for any particular patient I've seen since it was approved. I think the idea is really, really a good one. Give the chemo initially just to get people past that first couple of weeks, really, first month or 2, and then stick with immune therapy alone. But that's a lot of drugs, right? So 2 chemotherapy drugs and 2 immune therapy drugs. If you look at the toxicity in the trial, it actually looks tolerable. I would call it a tolerable regimen, but I think in practice, it's got to be more challenging for patients, since I think even just ipi-nivo on its own can be challenging, since it has this higher risk of immune toxicities. But, I think for some people, there might be select cases where I would consider it. So I think it's always nice to have options for patients and have that as a regimen that you could choose. But I think it really is for the select patients, at least at this point. Hopefully at some point we'll see some randomized data comparing these various regimen options that we have. But at least right now, I think it can be considered for select patients, but not my standard.
I gave it to my first patient just last week, and she was a patient who presented with 3A disease and resected and got adjuvant chemotherapy, and then in about 7 or 8 months recurred with extensive bilateral lung metastases, really kind of exploded in terms of her disease. And she had a PDL1 of 0. She had a TMB of like 10, 11 mutations per megabase, which is kind of intermediate. And she also had a KEAP1 mutation and an STK11 mutation, both mutations which are associated with worse prognosis and possibly worse response to immunotherapy. So for her, with a negative PDL1 and very aggressive disease and some resistance mutations, I thought giving her a more aggressive regimen like this was appropriate. What do you think, Sarah?
Yeah, in my mind, the ideal person for that regimen is someone who has a lot of disease, needs a response, but has a good performance status to tolerate it. But that's a tough patient to find. Someone who has so much disease that they need a good response, but then they have a really good performance status to tolerate it. But I agree, especially someone with a low PDL1 or 0 PDL1, where I'm worried that they won't benefit from the immune therapy. And the ipi-nivo data on its own in the less than 1% PDL1 patients is really promising. But if you think they also need chemotherapy, this might be the way to do it. So I think that's really, I'm interested to hear that you're using all of these various biomarkers that are, I would say, probably not necessarily standard, but it sounds like you're using them kind of as part of your calculation when deciding, but I imagine not as a sole deciding factor of when to choose these types of regimens, like the STK11 mutation.
Yeah, I think the more information you have, the better. Certainly there aren't biomarkers for some of the newer drugs that we're exploring. There's now randomized trials with a TIGIT antibody in combination with atezolizumab in different trials in non-small cell and small cell lung cancer. Your thoughts on TIGIT as a potential target? Do you have any? I know you guys have had some experience with it early on, as I recall.
Yeah, so I think that the phase 2 data for that drug looks really good in combination with atezolizumab. particularly in the high PDL1, the greater than 50% PDL1 patients. And so, yes, just like you're saying, there's now a randomized phase 3 trial in the first-line setting. So I'm excited about that. We have that trial open at Yale, and I think it's a great study. We already have talked about how for patients with PDL1 greater than or equal to 50%, we would typically think about single-agent immune therapy. But the truth is, it's not like everybody's responding. There's still plenty of people who aren't responding or who have a more transient response. So I think that still is an area where we can definitely do better. And so maybe TIGIT is the answer. We'll see. I mean, that trial is ongoing. So it'll probably be some time until we know. That's one of the ones I'm absolutely watching.
So this is a clinical situation, which I don't know what the answer is, but it occurs very frequently where you have a patient, they're PD-L1 positive, they get pembrolizumab monotherapy, and as you said, not everyone responds. The non-response rate or progression of disease is the best response is seen in about 20% of patients. The progression-free survival at 1 year is 50%. But they're PD-L1 positive. They should respond. And so when they progress, there's a lot of temptation to just continue the immunotherapy and add chemotherapy to it. And it's not something I routinely do because there's no data for that. But do you want to talk about your clinical experience regarding that and also the trials that are coming down the pike in that setting?
Yeah, I agree. This is an area where we could use some more data as well. There's lots of areas like that right now in lung cancer. It's like the more data you get, the more questions you have about what actually to do. But I agree, it's tempting to keep it going, especially in someone that has a high PDL1 and you think they might have benefited in some way. So it's not standard to keep it. There's no data that shows that we need to do that but there's also no data that shows that we don't. So there's just no data. So, in patients who have really any PDL1 expression, who are progressing, but I think they still are deriving some benefit. So they're progressing at, let's say, a few sites, but other sites still seem to be controlled. I think those are the patients I might consider adding chemotherapy onto it. Otherwise, with the lack of data and the potential toxicity of continuing immune therapy, it's not clear that we need to keep it on. I typically, probably more common than not, I just switch to chemotherapy. But there are patients where it seems like they're having you could either say a mixed response, where initially they have some things that respond and other things that are progressing, or they respond entirely and then at some point some things grow but other things remain stable or responding. And those are patients where I think maybe adding on chemotherapy to immune therapy might be appropriate. And I think until we have data, it's reasonable to consider adding it on. There's a trial, I know of one, maybe there are others, the Insignia trial. It's a cooperative group trial. It's asking a couple questions, and that's one of them. So, in patients who get, in this trial, pembrolizumab as first-line therapy at the time of progression, is it beneficial to switch to chemotherapy or to add it on? So exactly the question you're asking. I imagine that for some patients it's beneficial to add it and some patients not. So hopefully that trial or others will help us sort that out when it's okay to drop it.
Remember to visit morningcommutepodcast.com/NSCLC3 to receive your credit and evaluate this program. Drs. Rizvi and Goldberg discussed toxicities with IO therapy and the trial design of cemiplimab that enabled participants to remain on the immunotherapy. Let's rejoin our discussion.
You mentioned earlier that in our last podcast that toxicity can develop at any time. It's more common earlier, but it can develop even months or years into treatment. So if we can drop the immune therapy at some point safely, I think it's probably better to do that. Yeah. But if it seems that there's still some benefit, it's, I think, reasonable to continue it.
Yeah, there's a little nuance to the cemiplimab phase 3 trial randomizing patients to cemiplimab or chemotherapy in the PD-L1 more than 50% phase 3 randomized trial that was positive for cemiplimab. But what they did do in that trial for a portion of patients was the patients that progressed on the cemiplimab, they were able to add in 4 cycles of chemotherapy and continue the cemiplimab going. So you progress on cemiplimab, you keep getting the cemiplimab, 4 cycles of chemotherapy, then you continue the cemiplimab. So it'll be pretty interesting it's not exactly the same as the Insignia trial, but I think we'll also shed perhaps a little bit of light of how we can maybe turn things around by tweaking the cancer by a short course of chemotherapy.
Yeah, I think that I forgot about that. That was part of the design of the cemiplimab trial. I think that's going to be really interesting to see that data. I don't think they've released results on how those patients did when they had the chemo added on after progression on the single agent. But I think that's going to be really interesting. I'm glad that they put that in their design so that we could start to have an understanding of the potential benefit of that.
So I think it's probably worth, spending the last bit of this podcast, talking about non-metastatic. Before I get to that, I think it's important to note that, there's different types of progression, and, we've all had patients that have been on IO therapy and, for 3 months or 6 months or 9 months, and they may progress in like a lymph node or one area, like an adrenal lesion or a lung lesion. And your group has certainly published on this as well. We're trying to manage those isolated or oligo progressors with radiation or surgery, can actually allow them to maintain therapy on immunotherapy and translate into durable benefit. Do you want to comment on that work, Sarah?
Sure. So as you said, there are some patients who have this, really clear progression in one or a few sites, which is, people are calling oligo progression. Why it happens is not clear. We have in our group, and I know many others, been trying to understand progression in general on immune therapy. But I think this oligo progression really is so interesting, where many sites continue to respond and stay in a kind of a sort of remission state, but then other sites, one or a few, progress. And so the data you're referring to is a retrospective study that we did looking at our patients where we treated with local therapy. The similar pattern of treatment is what we've been doing for many years on patients on EGFR therapies, where in that setting as well, we sometimes will see oligo progression, and local therapy there seems to allow you to continue on the EGFR therapy for a while longer. And it seems to be the case here as well in that study. And then since that study, I've had many other patients that I've taken down this path. It really does seem to be effective, where it's just these one or few places that the cancer seems to be figuring out how to grow despite the treatment, but the rest of the disease is remaining under control. And so those patients can really potentially benefit from local therapy, whether that's radiation or surgery, or we've actually used some ablation with our interventional radiologists. I've seen done the gamut of things for patients depending on the site, usually less surgery, but occasionally it's appropriate. But it can be really effective. And I've had patients that have clearly progressed in one or a few sites and then can continue on the immune therapy for sometimes years longer after the local therapy. So I think it's a great strategy for patients. I typically will get a PET scan before I go down that path, because I want to make sure it really is just those couple of sites and there's not other things that are looking active as well. But I think it could be considered for some patients.
Okay, so I have another question for you based on your research interest, and it's a patient who's PDL1 80%. They come into your office and, they have, let's say, 6 brain metastases, each measuring 3 to 5 millimeters in size. Certainly in the past, we would give gamma knife to those lesions. In the era of targeted therapy, we may just try the targeted therapy for targeted therapy agents with good brain penetration. What about immunotherapy in the brain? What would you do for this patient?
So we are starting to see more data that immune therapy can be active in the brain. And so I think in some cases, we can absolutely see responses in the brain that are just as good as in the body and sometimes extremely durable. We had the study you're referring to is we had a study of pembrolizumab for patients with asymptomatic brain metastases. And on that study, we saw a few patients who had really, really durable responses, well beyond a year or 2 years for some of them. So before that, and that study and a few other studies similar to that, we really didn't even know if it could work in the brain. A lot of the targeted therapies, the TKIs, have clear brain penetration, but not really the immune therapies, but it can work. The question is it the right thing to do for patients? And we don't really know yet. I think, we don't have, our study was a fairly small study. There's a few other studies now that are larger, but mostly retrospective or subset analyses. So I think it's still early to say that you can use immune therapy instead of local therapy for brain metastases. I think in select cases, very select, you could consider it. in a patient like you're describing that has a couple of small lesions in non-critical locations that if they grew, they wouldn't run into trouble. I think it's worth considering if you think their chance of response is high. So that's typically a high PDL1 expressor. You have to watch those patients really closely, though. On our trial, we got brain MRIs every 6 weeks to make sure we weren't putting anyone in harm's way. So I think it could be a consideration for very select patients, but I think still using local therapy is the standard for the vast majority of patients. And there are some patients who have a lot of small brain mets where you'd really have to consider whole brain radiation. I try to avoid that at all costs in my patients. You know that with immune therapy, people can live for years, and whole brain radiation can really have long-term toxicity. So if that's the case, I might actually feel more inclined to try immune therapy on its own, in a case where they need whole brain radiation, or maybe think about doing stereotactic radiosurgery to a couple of the concerning lesions, and then immune therapy. But whole brain radiation is another story where I really would try to avoid that if possible.
Great. Well, that was a great overview of brain metastases. So for the last 5 minutes or so, I think, we want to sort of focus on earlier stage lung cancer or non-metastatic lung cancer. We now have phase 3 randomized data for patients who have unresectable stage 3 lung cancer that receive concurrent chemotherapy and radiation therapy, maintenance or consolidation with durvalumab, PDL1 antibody for 1 year, improves both progression-free as well as overall survival. This is definitely the standard of care. It perhaps has shifted more people away from trying to resect these tumors and maybe try to treat them with definitive chemotherapy and radiation therapy. Sarah, I mean, I think it's safe to say that's your standard of care. Do you want to comment on what you do with PDL1 0 patients, what you do with EGFR mutant patients?
So it's just like I was saying before, where we get some answers and then we have many more. So I agree with you. This is now the standard to use durvalumab after concurrent chemoradiation for stage 3 disease. Improvement in survival is, I think, clear. And so overall, it's the standard. But then there's some questions still. And one of the questions is with the low PDL1. So there was less benefit in the patients who had low PDL1. Whether there was no benefit, I think is still unclear to me. And so with the challenges in PDL1 testing and the definite lack of benefit, I'm not saying that exactly right, but I still use it regardless of PDL1. Maybe in someone who's a little more borderline, who had like a mild autoimmune condition, I might think twice because, you're weighing risks and benefits. But I still would use it in a PDL1 0 patient until I know better otherwise. Same with EGFR, patients with EGFR mutations were allowed on the trial. I think, we haven't really talked about this actually. EGFR mutant patients tend to have much lower response rate to immune therapy in general. They have lower benefit with this as well. But again, I don't think that means they have no benefit. So I still would consider treating them with durvalumab. Same goes for never smokers. I think they probably have less benefit with durvalumab, but it's still something where you don't know that they have no benefit. So I think it's worth using. I think the challenge, and again, this is a whole other topic, but the challenge is now now that we have kind of other adjuvant therapy for EGFR mutant patients that we might consider adjuvant osimertinib, which is better. I think because we don't know about adjuvant, it's not really called adjuvant, but we don't know about durvalumab in patients who have, who get resected, and we don't. And the data for adjuvant osimertinib is after surgery. I try to keep to the trials of what we know. And so for patients who have EGFR mutant lung cancer and get surgery, I'll consider adjuvant osimertinib. But if they have definitive chemoradiation without surgery, I'm still going in the direction of durvalumab. I would love to see data on which is superior. But as of now, without that data, I still think using immune therapy is appropriate. What do you do, Nair?
Yeah, I mostly agree with you. I think the data with adjuvant, osimertinib in resected lung cancers is so powerful. And then the number of EGFR mutant patients in the Pacific trial with durvalumab consolidation was relatively small that wouldn't be, FDA approved, but I would probably be more inclined to give those patients adjuvant osimertinib than durvalumab, because durvalumab, the adjuvant immunotherapy there are risks to it. And, although the risk of pneumonitis was not felt to be appreciably different, my personal experience is that it probably is more than without the durvalumab. And that comes to another question, really is you have a patient, they got chemo RT, and then they developed, after 2 doses of durvalumab, sort of in-field pneumonitis, not widespread. And it's a patient of mine right now who's on a steroid tapering course and he's improving. Do you go back to the durvalumab in those patients? I think the answer is yes. I think it would make sense to go back to them. Your thoughts, Sarah?
So I think there's probably a difference between, like you're saying, in-field, in the radiation field pneumonitis and more widespread. In a more widespread pneumonitis, I'd be more worried that it was actually the durvalumab that was causing it. And so I probably wouldn't in that case. Something that looked more like radiation pneumonitis, it very well could still be that the durvalumab was making that worse.
Right.
It may not just be radiation alone. But with some time to recover and get further out from the radiation, it's reasonable to consider rechallenging. I think maybe some of the things that I might consider are how severe was it? If it's grade 1 or 2, I think it's reasonable. Grade 3, I probably wouldn't. And then the other thing is, how likely do I think they are to benefit from the durvalumab? So I know I just said I would treat someone with a PDL1 of 0 and a never smoker and all that. But if it was that type of patient who developed a pneumonitis, I might feel less excited to rechallenge. If I thought the potential benefit was lower and they already developed a toxicity, I probably wouldn't rechallenge them. But someone who I think has a high chance of benefit and had a mild toxicity, I would think about doing it.
And then lastly, I think what's not something that's in our current availability of therapies, but I think will potentially could be soon, is the neoadjuvant treatment with immunotherapy in patients who have resectable lung cancer. We and others have published work combining PD-1 or PDL1 with chemotherapy, and the pathologic complete response with that combination is ranging in the 30 to 50% range, which is, pretty astounding given, the historical data with chemotherapy alone producing a pathologic complete response, probably in the 5 to 8% range. The phase 3 randomized trial conducted with nivolumab and chemotherapy, the top line data that it met its primary endpoint, and we look forward to seeing what that data looks like, and it potentially could be an approval in the future. It's not necessarily standard across centers in this country to give neoadjuvant chemotherapy for the good reason that there's not a lot of randomized data saying neoadjuvant is better than adjuvant, but these data are pretty compelling, and I think could definitely change the landscape of how we treat resectable stage 2 and 3A lung cancer. I'm sure you agree, Sarah, and any additional comments you have on that?
I agree. I think this is one of the most exciting areas of research right now in lung cancer is the neoadjuvant and also adjuvant data on immune therapy for early stage disease. So I think at some point we're going to be using it for early stage disease as well for resected patients. Whether it's neoadjuvant or adjuvant, with chemo, without chemo, I'm not sure because these trials are all ongoing, but I think the data looks so exciting. And with what we've seen in the metastatic setting and in stage 3, with the benefit there, I think it's going to translate to earlier stage disease as well. I think this is something that if we talk again on this podcast next year, maybe the year after, we'll hopefully be talking about this as a new standard of care. Not yet, and we are still waiting for the data. I think one thing that is clear from some of these studies is that it's safe. There's always concern with neoadjuvant therapy that you're going to make someone inoperable or unresectable and uncurable. But I think from the studies we have so far, it looks like it's safe. You do sometimes get immune toxicities, but patients are able to get to surgery in the vast majority of cases, and it doesn't seem to delay things significantly or cause major problems. So that's very reassuring. And now it's just the question of, the important question of, does it improve survival? So we will see. I'm excited about that data. Hopefully it will change practice in the future.
Great. So, we haven't had a chance to discuss, but there's a number of other newer therapies on the horizon in lung cancer, combining VEGF TKIs like lenvatinib and sitravatinib with immunotherapy. There's cell therapy approaches and many others. So it's clearly an exciting time for immunotherapy in lung cancer. Thank you, Sarah, for your great insights, and thank you, audience, for listening.
Thanks.
Thank you for joining us today. Remember to go to morningcommutepodcast.com/NSCLC3 to receive your credit and evaluate this program. If you've missed any of our episodes or would like to listen to them again, please visit morningcommutepodcast.com/NSCLC to find a listing of all 3 podcasts.